So there isn't a great deal of housekeeping because we're virtual today, but the main thing will be put your questions in the Q&A. That's what I'd really like to see as we go through the presentation. Just to give you a bit of an introduction, I'm Will Haydock. I'm the director at Collective Voice, and we bring together and represent the charities that provide drug and alcohol treatment across England. So we try and do three things. We try and influence policy, we try and improve practice, and we try and build public awareness and understanding around substance use issues and treatment. We've also got a whole range of organisations and individuals from beyond Collective Voice here today. We've got people from, as well as charities, from different bits of the NHS as well, and right across treatment. So we're really enthusiastic about the wide variety of people we've got here today. This webinar is not a lecture. It's not a kind of chalk and talk. It's not about showing off how wonderful Collective Voice is or any single one of our organisations. Despite the speakers being wonderful and doing wonderful work. The aim is really to bring people together so that they can understand more about what's happening in the sector, and we can build a network of people who are really looking to share good practice and reduce harm related to ketamine. And a lot of the things that people will be describing here today is work in progress. So we're not saying that we have all the answers and this is how to do everything. We have a lot to get through, but we're really hopeful we'll be able to carve out some time for question and answers or discussion. This isn't just about asking questions to experts who can give you a definitive answer. I think given the number of people we have on the webinar today, the easiest way to do this is for you to write what your question is in the Q&A section. And then if you've seen a question that you're interested in, then please like that, and then we know which questions to prioritize. So that will be the best way for us to keep track. I've seen a couple of questions in the chat about sound, but it does seem like some people can hear things and others can't. So if you are struggling with sound, what I'd recommend is that you leave the webinar and come back in, and hopefully that'll work for you. But as I say, we are recording this, so there will be a chance to watch it back in your own time if you can't get things to work today. So I'm now going to hand over to the first of our presenters, which is Rob Ralphs. I'm not going to introduce our presenters in great detail so that we can save on time. And hopefully soon the slides will load and I'll be able to hand over to Rob. Great. Rob, are you in control of the slides?
Yep.
Perfect.
Yeah,
well,
good.
I will hand to you.
Okay, thanks, Will. So I'm going to do a very quick whistle-stop tour of some research we've been doing in the last couple of years in Greater Manchester. We've been focused on emerging drug trends and in particular young people and ketamine use. And what we kind of highlighted from that research is that it's increasingly being used as a kind of primary substance rather than something young people would be using occasionally. There's a younger age of use, so lots of services reporting seeing people as young as 12, but more typically kind of 14, 15. With that early onset of use, we're seeing an early onset of harms, typically more in kind of like late teens, early 20s. And we talk about now shifting to beyond a club drug. Obviously, ketamine's been around for kind of 20, 25 years. One of the main club drugs alongside MDMA and cocaine. But what we started to hear was this narrative of young people using it beyond that kind of clubbing, electronic dance music scene to self-medicate anxiety, as you can see here, self-medicate depression or isolation, loneliness. And when we spoke to professionals who were working with those young people who were using it daily, they were in kind of tier 4 treatment needs, they're using upwards of 1 gram a day, sometimes up to 7 grams or more a day. This kind of consistent narrative about kind of trauma and self-medicating and adverse childhood experiences come up. So that kind of need to address these kind of underlying kind of mental health needs as well as something that come through. Another consistent theme was the fact that quite often people are presenting at services when they're in tier 4 need, they need community detox, they need referrals to urology. So this thing about needing to engage with young people earlier. We found one of the barriers to this is this kind of lack of understanding of what the options are, and this kind of real kind of simplistic understanding that if they use ketamine, then they'll kind of end up if they kind of seek help with kind of the bladder removed and wearing a urostomy bag, etc. And this was kind of putting people off that kind of earlier engagement with services. We also picked up on a lot of kind of poor harm reduction information. So young people either didn't really know about the risk, or if they did, they're under the misconception that as long as they crush the ketamine up to a fine powder, then they'll be okay. And finally, it's not just about those kind of awareness raising for young people. We found the need for similar thing in the medical professions. So lots of reports of GPs, kind of pharmacists, A&E nurses and consultants, not really kind of understanding ketamine. People repeatedly going to pharmacists, GPs, A&E linked to the ketamine use, but not really kind of being satisfied with the response, and quite often not even being asked about whether the symptoms could be linked to ketamine. So whistle stop thing there. I'll end it there because I think I've gone a minute over my allotted 2 minutes.
That's brilliant. Thanks, Rob. I appreciate that. I'm going to take back control of the slides, but Pete, it's over to you. If you're happy for me to be the clicker, or if you would like to just click take control.
Have I got it?
You've got it. Yeah, go for it.
Okay, hi everyone. I feel like the sprinter on the blocks on a relay race or something. But yeah, so this is going to be rapid. This is a few slides taken from a deck that we put out, that we cascaded all to local authorities, and hopefully this has reached some of, if not all of you. I just wanted to spend time on the bit where we describe a treatment system, and not just the treatment component, but the whole sort of health and care system that should be sort of in place to respond to this properly. A lot of this is easy to say. I appreciate that some of this is difficult and there'll be implementation difficulties, but really important that everyone kind of stays sort of focused on the aim of trying to achieve this. So just a few statements about treatment itself. Really important to get the front door right, to get the service promotion right, so people know that this is for them and that they can access it. And as Rob said, really important to get earlier intervention. Treatment needs to be purposeful. Psychosocial interventions, which I'll talk more about, that's going to be the mainstay of this. There is an indication for inpatient and residential care for people that have got more severe and complex needs. But we really can't let go of the fact that the vast majority won't need that, and we need to get them earlier, and the interventions need to be person-centered, adaptive, and layered and sequenced. So that's shorthand for, you're going to need to do different things at the beginning, the middle, and the end, and you're going to need to ramp it up when you need to. Final point about treatment is there is lots of kind of comorbidity and complexity here, and physical and mental health problems. So multidisciplinary teams are really helpful within that. So having nurses, psychologists and people in teams are really important. Pharmacological, there isn't a lot of pharmacotherapy for this. Low dose benzos as the starting point. There's no studies on anything else. There's going to be might be need to be links to pain management in partnership with urology, primary care and pain clinics if appropriate. And you need regular health checks to ask about urological problems, and routinely screen for mental health and make supportive referrals to mental health services. So psychosocial interventions, what we know is people with clear techniques and belief in them, proper supervision, i.e. checking out how they're applying those techniques and developing those techniques, and the quality of the working alliance that you have with someone, those are the things that are going to influence outcomes. It's true for everything, really true for ketamine, partially because there isn't the kind of the pharmacotherapy there. Really need to pay attention to all of that. An element of a psychosocial intervention needs to be substance specific, but a lot of it isn't. You need to understand how it affects the body and the brain, but also what's really key is a really robust formulation. So understanding why people use, the triggers, the context, the function, and all the maintaining factors of the use. And then what evidence indicates really works in terms of structured support is a strong therapeutic alliance, session structure, knowing what you're going in to do with the person, goal direction, those can be small and incremental, interventions to develop alternative rewards and activities, engagement with positive social networks, so doing something else in a nutshell, and helping people build their self-efficacy, so their belief in their ability to do something and to make changes. So this treatment isn't going to be able to do this alone. You can use combating drug partnerships to bring in other partners who can help with the system. Children and young people services will do the same as adult and young adult treatment services, but also need to do targeted awareness, raising advice and information, good pathways and links with urology and primary care. Sexual health services will also have a role, as will youth services in terms of screening, identification, early referral and brief intervention. And mental health services are going to be key. We also need to make sure that emergency departments are able to spot damage and screen and refer into treatment. Too long, Will, but I'm out.
Thanks, Pete. That's brilliant. Really helpful. Great kind of scene setting. Rebecca, are you okay to take over?
Yep. All good.
Brilliant.
Hi, everyone. Thank you so much for inviting me here today. This was a paper that I published this year with Professor Celia Morgan. We realised that there was a real lack of research into ketamine use disorder, and so we decided to design a survey to investigate the patient experiences of ketamine use disorder, their symptoms, and their experiences of treatment. And that is both associated with their physical symptoms and of their seeking treatment for their addiction itself. Haven't got time to go through it all here, but if you do scan the QR code or give the title a Google, you can read more about it. But in summary, we had a total of 274 respondents with either a current or previous problematic ketamine use. About 50-50 split with females to males, and the majority of the sample were current ketamine users, and they were non-treatment seeking, with 73% saying that ketamine was their primary drug of choice. The most common route was of administration with insufflation, and interestingly, 4 users at first sourced ketamine through a clinical prescription. This survey wasn't limited to the UK, so we imagine that that was from the US, where it can be prescribed more readily. The average use per day was about 2 grams, but the maximum that we had that was reported was around 20 grams. And in terms of the survey results, thinking about their treatment experiences, 34% had sought treatment for their physical symptoms by either a GP or A&E, but only 36% were satisfied with this. You can read more about the qualitative experiences in the paper itself. And in terms of seeking treatment for their ketamine use disorder, participants reported that services had little or some awareness of ketamine, and the majority reported that that services were not tailored to their ketamine use. And most participants felt there was an insufficient awareness about the risks of ketamine in education and amongst peer groups as well. And the conclusions that we made from the survey results is that there is a need for better education and awareness about the negative effects of ketamine use, both amongst healthcare professionals and the general public. There is a need for improved evidence-based tailored treatment approaches for ketamine use disorder, and we need to reduce the stigma attached to ketamine addiction. And there needs to be further research investigating new treatment approaches, potentially pharmacological interventions as well, to better support individuals. Thank you.
Lovely. Thank you, Rebecca. Irene, are you happy to take over? That was a really clear kind of outline of some of the challenges we face.
Yeah. Thank you. Thank you very much. I think I can control my slide autonomously. Let's hope so. Okay, so the PF ketamine project started about 3 years ago when looking at figures, and it was apparent, visible from my point of view as a clinical lead, there was a significant increase in very young patients attending the clinic, as young as 17 and a half. My clinic is an adult, so it's gathered for 18 and over. But it was, and all of them, as I say, come in more or less with quite severe ketamine addiction. So we said, okay, we need to start thinking about developing some pathway. So the first thing we did was, in fact, to look at figures, and in order to tailor and to make the intervention more specific for these younger people. Okay, I think I messed up. Just one sec, I can't turn. Okay, now I can turn my slide. So overall, we look at retrospectively to 100 cases they attended for tier 3 treatment. They were predominantly male, which are quite a mean age of 25. We look at how many of those were below the age of 25 when they actually entered the treatment, were quite proportional, around 37%. The amount of ketamine obviously was variable, with a mean of about 3 grams, with plus and minus about other 2 grams on top, with occasional use of about up to 16 grams. But what it was also quite important to highlight was the extent of reported ketamine neuropathy, which was about 40% of the cases, and 66% of mental health problem. So if we look at the next slide, okay, let's see. Okay, the next slide. Here it is. So I'm not going to go into details. We divided the group in 3 categories according to the frequency of use. And as you can see, there was a kind of crescendo between in terms of ketamine-related neuropathy between the infrequent users, which were affected only 14%, to up to 62% in the daily users. So this, in my opinion, is a good indication that harm reduction, early intervention is very important to avoid the daily users to suffer more about ketamine neuropathy. Also, the repertoire of drug use is reducing when they become daily users. Only half of them they were using other drugs, mainly alcohol, cocaine, and cannabis, compared to nearly 80% of the infrequent users that were mixing a lot of other drugs together. So if we move to the next slide about mental health problem, again, you see the same effect in frequent users. The very a low proportion of mental health problem compared to daily users. And if you look at a classification of condition, mainly depression and anxiety were very high, but also you have to look at, for example, quite a big proportion of them reported the trauma, which could be trauma in childhood, the different type of traumas, and also deliberate self-harm. So quite heavy mental health problem. Obviously, at this stage, I haven't completed to analyze this case series. At this stage, I can't say what is primary, what comes first, or what is secondary to chronic use of ketamine, but the indication is that there is heavy comorbidity in this group. They need treatment. And we did a brief survey with our service users, so mainly asking what they wanted from services. And again, as said by Peter before, is the fact that professionals do not understand addiction, ketamine addiction fully. Services are mainly tailored for Class A drug users, not specific for ketamine. For example, group, it can be difficult for somebody who need to go to the toilet quite frequently if it's not a ketamine group, but it's a mixed group. And then they don't relate with other type of users, embarrassment, and general lack of understanding. I think these are the themes that were already discussed in the previous presentation. Thank you. I think I've finished with my presentation. Brilliant. Thank you for the attention.
Thanks, Irene. Really helpful to see that perspective. I'm going to hand over now to Lisa to give us a bit of an intro to some work Acorn are doing, and then we'll show a video which features some testimony from people with lived experience of use of ketamine and treatment.
Thanks, Will. So good afternoon. As Will just mentioned, I'm going to move the conversation onto the practice of using client lived experience in service settings. So as a service, we sought to listen to our ketamine clients so we could learn what their experience of being in treatment with us was like as individuals and as a group. And our aim was to use this local knowledge to co-produce solutions that would make treatment more welcoming and empowering. And from this, a number of new measures were introduced. For example, flexible group working, discrete management of dignity barriers, and adaptive travel arrangements. So what we've seen is our treatment outcomes indicate that this approach is working very well, with ketamine clients in our residential rehabilitation service continuing to record strong completion rates. In analysing the data or the conversations we've had with clients, a consistent theme emerged, and that was the strong need for peer support. And our ketamine clients sought identification with peers facing similar issues beyond what the mainstream mutual support groups provide. So the clients wanted the opportunity to talk about often sensitive issues in a forum which understood through experience to help guide and share recovery as a group. So as a joint service and client initiative, we launched the Ketamine Care Hub in response to this. A decision that has not only been of significant benefit to the treatment experience of our clients, but has also empowered them to shape what recovery looks like in the communities they return to. So our clients are actually the testament to this, and they have produced a video sharing their voice, which, technology permitting, Will is now going to show.
Okay, let's go for it. Let's see if I can manage that. I'll get the slides back up and should be ready to go. This worked in practice, so let's see if we can get it to work in reality. So thanks for sharing that video and your introduction to that group, Lisa. I'm sorry if anybody wasn't able to properly hear or see the video, but we will be sharing that along with the slides. We're able to do that. So hopefully you'll have full access and we can share information about that particular group as well. I'm going to hand over now to Deb, who's going to talk a bit about her own experience of ketamine-related harm. Hopefully this will all work in terms of being able to unmute and so on. But let me know. There you are, Deb.
Hi, thank you, Will. Yes, so thank you everybody for sort of, inviting me. I mean, everything that has been said thus far completely and utterly resonates with my experience. I've unfortunately had 2 children with chronic ketamine addiction. My firstborn, he started using ketamine when he was sort of 16, 17 on the club scene. And like, has been mentioned already, this sadly developed into a daily habit. And along with that daily use came all of the usual chronic physical health problems, acute pain, bladder uropathy, I mean, everything, acute depression, anxiety, total isolation, ended off going to rehab. And actually, when he was in rehab, he really enjoyed it because I think he really felt enormous relief being away from the opportunity to use, but couldn't cope with the reality of not being in a rehab. And I think one thing that we really need to be mindful of is that with ketamine, I think it's this massive issue of pain management, which is such an issue. I noticed with my son, what he would do is he would go to fellowship meetings and say, yeah, tomorrow it's going to be a fresh start, really going to try and do this. Then he'd be in the most terrible pain. He would lie in the bath for hours in the day. He wasn't working, just with the hose on his stomach, trying to relieve the pain, messaging me at work to say, please go to Boots and buy the strongest thing you can buy for me. Of course, nothing touched it. And he would then go and use ketamine because obviously it provided the short-term relief he needed. And so that vicious cycle, pain, use some more ketamine, even more pain. When he was in rehab, not being able to sleep because he was up going to the toilet 20 times a night because his bladder had shrunk to such a degree. And it really was a terrible experience for him. Also, I know it's something that Irene picked up. We live in London. His experience of going to A&E when he was desperate was that people really didn't know what to do. They didn't understand ketamine. All that would happen is he would trawl from different A&Es to different A&Es and be prescribed with really strong opioids. And when we were desperate for, we were absolutely desperate for some more residential treatment, I found that the area we live in was an absolute lottery postcode wise, and we were both told, you need to stay clean, and if you can stay clean in the community, then we can look at taking you into a residential facility. And sadly, he just could not cope, and he took his own life. So yeah, I've seen the absolute horrific destruction. And as I say, he started using when he was 16, 17 at a festival, and he was dead by the time he was 21. So yeah, I'm really glad that there's so many sort of experts here together looking at how we can, you know, do something proactive in this terrible epidemic. So thanks, Will.
No, thank you, Deb, for sharing and taking the time to share, as people have put in the comments already, the poignant story, and the importance of learning from what has happened in the sector, how we can improve services. You've talked about some of the key moments and issues there that hopefully we'll be covering in the remainder of the webinar. So covering harm reduction and early intervention, pain management, and residential treatment as well. So hopefully by building this network, we can make a difference for people so that there are fewer tragedies of this kind in the future. So I'm going to hand over. Thanks again, Deb. I'm going to hand over to Lydia.
Hello, I'm Lydia. I'm the Chief Exec at Bristol Drugs Project. BDP have been running services around ketamine since about 2006, 2007. And a key part of what we do is around harm reduction and early intervention. And I think it's really important just to highlight that this isn't about not taking ketamine seriously, as we've been hearing already. Ketamine is can be a really harmful substance for a lot of people, but also what we've been hearing is the importance of kind of earlier intervention. So I've been seeing a lot of comms and a lot of flyers and people trying to engage around ketamine. There's a lot of the kind of just say no information out there. There's a lot of kind of focus on the really harmful and the really sad end, where we're seeing people with really chronic dependence and physical health needs. And what we're trying to do is focus some kind of engaging comms around getting people into treatment earlier. So what we're seeing are people that are coming into treatment after they've been using for years and years and have seen significant damage. So some of the ways that we're doing that is by having really accurate evidence-based harm reduction information. We go out and do club and festival outreach, as we've heard, and people often start their ketamine using journey out in the nighttime economy. So it's about engaging in that space, and also engaging with schools and universities and having really culturally competent kind of communication with people. So just as we kind of phase and layer our interventions, we also need to phase and layer our outreach so that we're kind of gaining trust and gaining people's kind of credibility so that they are more likely to come into service and believe that we know what we're talking about when they are ready to make some changes. So I'll pass over to Al now, I think, to talk about a way that he does that.
Awesome. Thank you ever so much. So, hi, I'm Al. I work for Cranston. I was a frontline drug worker for 12 years. What led me to drug treatment services was ketamine as a personal issue. And I've recently transitioned into a content creator because what I realized is that drugs and purchasing of drugs is like just so in the limelight, right? But the messaging isn't so mainstream. So we wanted to take a little trial to TikTok, and we're somewhere in the region of between 17 million and 20 million views so far on ketamine harm reduction. And what I wanted to share with the wider group is we really want to look back at historic learning from how we message around drugs, like all the stuff, how we responded to heroin. And as Lydia said, like the just say no isn't giving us what it needs to. We need to have far more well-rounded conversations. And what myself and Josh, who have been working closely on this subject, have realized is there's an absolute appetite for meaningful harm reduction within a new drug using generation, right? And I'm just slightly anxious and slightly worried that if we don't get the communication right, we are setting up the new generation of the drug using community the wrong way. So things that I want people to consider when they're talking about it is at times there's a bit of a battle between harm reduction and recovery, right? We need to even that playing field because both are valid and both are absolutely needed. And what I'm scared of is if we perpetuate a battle like that, the new generation are going to pick up on that, who already understand that harm reduction is viable and so is recovery. So like the conversations that I've heard are, that illness is happening a lot quicker, and that's why we look at harm reduction responses, and also sort of like things that have been handed down from drug using community from generation to generation, really. I won't go into them now, but if anybody wants to follow the TikTok, I'll drop it in there. But let's make sure we're having well-rounded conversations that aren't perpetuating internal battles that we've seen historically, and making sure that we are looking after people when they need them and developing services like what we do. So just moving away from the whole shock and awe. I think the shock is already there, and we need to make sure that we are just modernising and doing everything as we should. And that is me. Thank you very much.
Lovely, thanks, Al. A great reminder of some of those classic principles of harm reduction that we need to learn from and not forget. I'm going to hand over now to Lauren.
Can everyone hear me all right? Amazing. Cheers, Al. You're still on my screen, so I appreciate the thumbs up. I think, my name's Lauren. I'm a manager within CGL, 625 Outreach Services, which are our dedicated services around harm reduction for young adults. Kind of leading on from what Al was saying, I think it's quite important that we kind of understand and kind of accept that there's different kind of nuances and motivations for ketamine use as well. So when we're kind of targeting a lot of those harm reduction messages, we've got to kind of think about how they can vary and change, and there's got to be fluidity to that messaging as well. So thinking about those from perhaps rural settings who perhaps aren't as engaged with that kind of club or rave culture, we have to kind of adjust the tone there. Thinking about kind of age range of use as well, when we're kind of seeing, kind of average age users of like 14, obviously we've got to kind of take a kind of measured approach to the messaging. Probably a few kind of things to mention is when we're kind of looking at developing content and putting harm reduction messages out, particularly in like places like literature, social media, etc. Average reading age in the UK is like 9 years old. So when we're thinking about, again, how we kind of structure in that measure that kind of messaging, we do have to be really kind of cautious there, and also considering that there's quite a lot of conflicting messaging out there. We've kind of seen sight of a lot of these things that pop up, particularly in kind of social media based spaces. Young people tell us quite frequently that kind of aesthetic is everything when we're developing a lot of the content as well. It might seem like quite an obvious solution, but kind of co-production should be at the heart of a lot of what we do in terms of the developing of resources and kind of getting messaging and content out there. It's quite interesting because when we're kind of having a lot of conversations with young people and young adults, mainly the kind of issues when it comes to harm reduction, yes, ketamine is present, but there are quite a lot of additional issues that kind of come up there as well. So like, for example, when we're having conversations with like young women, they talk quite a lot about concerns associated with like spiking, drug facilitated sexual assault, kind of centering around ketamine use. When we talk to young men, there's a lot of conversations that center around social supply, like financial issues. Students tell us like really frequently about their concerns associated with like academic repercussion as opposed to kind of legal repercussion in those types of areas. So, there's quite a lot of kind of nuanced areas when it comes to this. But one of the kind of biggest things that dominates that conversation at the moment is kind of issues associated with like adulterants. So we've got to be kind of really mindful about how we structure a lot of that messaging so that it comes from a kind of place of integrity, and it kind of, again, talking about co-producing messages, etc. We want to make sure that young people are actually at the heart of that development of those messages that kind of center around those topics. So I'm going to pass back over to Lydia, who's going to go in a little bit more detail about that. Thank you, everyone.
Thank you, Lauren. So yeah, I just wanted to pick up on the issue around adulterants. So in Bristol, sadly, we have experienced at least one death of somebody that was using ketamine independently, but toxicology later showed some nitazines involved in their death. And I think just in this, with the drugs market being what it is at the moment, we have to be really, really careful about a group of people who are likely to be using different substances together, so polydrug use alongside their ketamine, and who may have some adulterated substances. So we believe that people using ketamine should be issued with naloxone, should be having discussions about how to access drugs checking, the loop, Wedanos, to use reagent kits, to engage with harm reduction measures around that. And that people should understand that the supply of ketamine could be adulterated, and the purity of ketamine and strong ketamine is an important conversation as well. But we need to really be kind of speaking to people about what might be in their substances. It really concerns me that there's a huge bunch of people out there that have no access, unlike people that use opiates, have no access to drug services, don't have regular content and contact about what's in the supply at the moment. And we've had some success with engaging with people around that. And people are really, really keen to talk about what is in their drugs, and anything that gets people through the door of a drug service or us out to them to be able to engage around what they're using and harm reduction. It is just going to bring us kind of more success with getting people into services early. So it's conversations worth having, both from a harm reduction perspective, but also about kind of increasing people's belief in our ability to talk about ketamine well with them. Okay, back over to Al.
Yeah, so I think what we want to try and do is like a bit of a group is we're going to pull some of like people who are particularly interested in harm reduction and look at sort of creating some uniformed messaging across the sector, kind of in the vibe of like the Staying Safe campaign that a lot of people did around when the opiates and nitazine started to become an issue. So kind of just keep your eyes peeled for that a little bit. We're going to start working on it, and then we'll do like a call to like bring more people in. But I think a uniformed voice on this from a spectrum of services feels really good and important. So I think that's as a little collective what we're gonna spearhead on the back of kind of just being put together really and connecting.
Great, thanks Al. And that picks up on something we're keen to do throughout this webinar and through a network kind of going forward, which is keep those links together, not pretend that we've got all the answers sorted or that everything's perfect right now, but we need to keep those conversations going. So we'll be in touch with people. As I say, we'll share the slides and so on, but we're keen for this to be an ongoing conversation right across the sector about how we can make sure services are genuinely accessible and effective. I'm hoping we'll still have some time to do some Q&A as we go through the session, and if we don't pick up on everybody's questions, again, we'll try and make sure that we pick those up with people outside of the meeting, because we'll have them through the chat. But now we're going to move on to discuss tier 4, so particularly detox and residential treatment. And I'm going to hand over to Jess, if you're happy to take control of the slides.
Yep, thanks, Will. Hi, everyone. So I'm Jess. I'm Head of Residential Access and Placements at Phoenix Futures. And today I'm here with Jo from Birchwood. She's the registered manager there. I've got Mikey with us too in the room, who's going to be sharing some of his experiences, and also helping out with this section is Lauren, who is virtually with us, and John Islewood, who is the Chief Executive at Broadway Lodge and also the chair of the Choices Group. So we're talking to you today from the Collective Voice Tier 4 Forum. So we represent a number of residential detox, some inpatient detoxes and residential providers across the country. So whilst we all work for different organisations, we are talking on behalf of us all today. So a bit of scene setting for you. Like in other areas, we're seeing a significant demand for our services for people using ketamine. The nature of these presentations has shifted noticeably, and there is a change in demographic, particularly seeing younger people who are treatment naive. They're presenting with increased physical health needs with evidence of lasting damage prior to admission. We're also seeing an increase in emergency assessments and admissions, with people tending only to be getting funding for residential treatment once their physical health has dramatically declined, rather than it being considered as an earlier intervention. People told us that they've been begging for residential treatment for over a year before they were considered. Quite often, people have been using ketamine that we're seeing have been doing so for a shorter period of time in comparison to those that come to us who are using other substances, and this is because of the impact mainly it's had on their physical health. When they are with us, we often see they've got a significant number of external physical health appointments and often delays in accessing those wider healthcare pathways that they need. We're also seeing an increase in mental health needs, including suicidal ideation, and this is often linked to the significant physical damage and the prospect of that not improving. Generally, on a day-to-day, we're needing to increase clinical prescribing for wider needs than we typically have done before, such as for wound care for urine burns. Additionally, we have an increased need for district nurse support during their stays. There is often more family and loved one involvement, and we're finding we're needing to provide increased support beyond the person we're supporting in service. There's been a significant increase in costs, so not just daily consumables, but to physical environments, additional staffing needs and capital expenditure. So further costs for staffing include things for higher ratios or one-to-one support, as well as for staffing with specialist skills. The funding model has remained static and not adapted to respond to those additional costs, but also typically only 12 weeks of residential treatment is given, which is a short programme anyway, but due to the needs and the other needs that people have, such as appointments, people are unable to get the full benefit of the programmes within that time. So we're of course supporting requests to advocate for further funding and do our best to explain the clinical need for this. But often budgetary constraints are given as the reason for not extending, not a disagreement in the clinical need. So the pathways for care to access healthcare are often hard to access and have significant waiting times, which doesn't allow people to get the support they need when they need it, or sometimes even during their stay in detox or residential. And currently suitable aftercare for recovery and physical and mental health for Apache, and we're therefore seeing reattenders. And lastly, people are continuing to experience significant stigma in healthcare settings. So I'm going to hand over to John, who will share how residential services and detox services have adapted.
Thank you. Thanks, Jess. Good afternoon to everybody. I'm really pleased actually to be able to say how much inpatient detox and residential services have adapted like so many other services for ketamine. And they are continuing to do this. This is the journey we're on, so we respond and adapt. And I'm going to speak on behalf of the sector about what has happened and give you a flavour of some of those things. But first, let me just cover off, we do have suitable environments, and many of us have ensuite and single rooms. And that's really important for people with ketamine who are coming into recovery. We've also reviewed our admissions criteria, and we've flexed this based on individuals' needs, particularly around medication and especially around pain management. We've had to, in a number of cases, purchase vehicles or additional vehicles so that we can support access for people to get to appointments where public transport or taxis are just not appropriate. We've also reviewed, as you would expect, our staffing needs, and in a number of cases responded. For some, this means an increase in clinical staff, nursing care, staff with specialist skills, or more staff to help with one-to-one support and increased ratios, or just a realization that all of this needs doing for those who are with us who use ketamine. And we're also adapting the program structures, timetables and contents, very cognizant that people might have to leave rooms, might need the toilet, etc. And as we've heard from so many others today, we're continuously advocating for specialist support for people, educating others, supporting them, such as GPs, and also challenging stigma. Now, in the slides you'll receive today, we've included a number of case studies, which I can't go through with you here, we don't have time, but I hope you'll find them very useful and you'll get them as a result of joining this webinar. I'm now going to hand over to Joe to hear some lived experience.
And we're able Sorry, guys. So we were able to speak to people in residential treatment for ketamine, and we're able to see what their barriers were to accessing treatment. And a lot of people said, you know, embarrassment was a huge part of this, stopping them from accessing treatment. And then the stigma that we hear throughout the webinar, that is still an ongoing issue. The lack of specialist support and the poor mental health, that decline within the mental health, and the fear and paranoia of accessing services and treatment itself. The trauma and the abuse that people have gone through is kind of stopping them from wanting to progress. And then a belief that ketamine is not taken seriously by healthcare professionals, and that could be also a lack of knowledge for them themselves. And pain is a huge one. You know, we see people unable to access community services and inpatient because they're concerned that pain will not be managed. So I have Lauren and Mikey here today, who have both been through residential treatment themselves in Tier 4 and are going to share their stories with you today.
Hi everyone, my name is Mikey. I'm a recovering ketamine addict. I was 16 when I first took ketamine and I used for 10 years. When I first took ketamine, I didn't use it on its own. It was with a mixture of drugs, including pills and magic. The physical effects that it had on my body were horrific. My kidneys, my liver was significantly impaired with changes to my bladder, causing reduced capacity and frequency in urination. The passing of clots and mucus alongside ketamine cramps were the worst pain that I've ever endured. My weight reduced by over 6.5 stone. My short-term memory still affects me to this day. And UTIs were a common occurrence, and I continued to use to numb the pain. Ketamine affected my relationship at the time, causing erectile dysfunction and pushed me away from intimacy. I wanted to end my life due to the pain, but this was not an option for me as I did want to live. I started to seek help from the Drug and Alcohol Service, who gave me hope that I could recover. The relationship with my mum at the time was close, and she went through so much trauma, seeing me in physical pain and crawling on the floor, asking for help in the middle of the night. I felt like my body was failing and something had to change. After finding the right doctor who understood ketamine, I was referred to a drug worker who assessed me within a month. Birchwood, the inpatient unit, accepted my referral and I went in for a 2-week detox, and I lasted 8 months drug-free. I then relapsed while I was on holiday and things escalated very quickly. I went back to the drug service for a second detox. Pain relief is linked to continued ketamine use. If GPs and hospital staff started to look outside the box and started to look at ketamine substitute medication, it may assist with pain management before treatment can commence. People I know found it much easier asking for naloxone if they said they were on heroin than trying to obtain it for ketamine use. Why are we begging for potential life-saving treatment? I'm now currently 19 months drug-free and I'm now healthy and happy. I work as a support worker back at Birchwood. I help others and I hold my own group for those with lived or living experience. Change is needed. People need early interventions. Healthcare professionals need better training. Waiting is not an option, and improved harm reduction should be available to all. When I was asked to attend this webinar, I did write an essay about my addiction to ketamine. Now, I know that time will not allow me to tell you my full story, but the professionals learn from people with lived experience, and my aim is to continue to spread the word and save lives along the way. Thank you.
Thank you, Mikey. Hi, I'm Laura and I'm also a recovering ketamine addict. So I started using drugs recreationally when I was 19. That was 20 years ago. But when I tried ketamine at 27, everything changed. I fell in love with the dissociation and the way it got me out of my own head. It quickly became my drug of choice. So what began as occasional use really quickly spiraled into daily dependence. 10 years ago, I realised I had a problem. I was then using 1 gram a day, which I thought was a lot, but my tolerance just kept growing and my need for chasing that K-hole did too. So during the pandemic, my use really exploded due to the stress I was under. I actually teach adults, and I was still working. So some days I could take up to 20 grams, especially around payday. And ketamine obviously completely ruined my body. My experience really does mirror Mikey's. The difference being for me is that the inside of my nose died, it became necrotic and I needed surgery. I also repeatedly had gastritis, which during the pandemic I couldn't have treated because everything was shut down. where my stomach lining had dissolved. I lost full control of my bladder alongside my dignity, and for a long time was having to wear incontinence pads. The physical pain for me was absolutely intolerable, unbearable, constant and utterly horrific. And with this, my health collapsed alongside, my mental health went as well. And something I just want to bring forward is that we talk a lot about trauma. For me, there was a lot of trauma around that pain that ketamine caused me that I have had to discuss and still do discuss. So I put off seeking help for years for fear of my son being removed from my care due to the stigma around being an addict and a parent. When I finally did reach out for help, I was told that rehab wasn't just a quick fix, and I needed to reduce my use in the community first. This is not something I could do. I was way too far gone in my addiction, and instead I was offered 7 sessions. And because that hope of rehab was kind of I felt like it was snatched away. 4 months later, after repeated hospital visits, feeling failed by the system and completely hopeless, I attempted suicide on 3 occasions, and this was due to the constant pain and this feeling of lack of understanding. Every time I come into contact with someone, I was teaching them about ketamine, so I just didn't feel like that support was there. I also went and begged to have my bladder removed. I paid privately to go and see a consultant, and I was willing to pay for him to take that out. This is where I was at in my addiction. Obviously, they've refused due to ethical reasons. When I was finally admitted to rehab 16 months later, I was really close to death. I was barely 8 stone, unable to walk, unable to sit. Had recently spent 10 days in hospital, was urinating blood, living off yogurts, and I vomited almost every meal I ate for the first 7 weeks being there. So my message is simple. When ketamine users ask for help, especially those reporting bladder damage, they must be taken seriously and fast-tracked into treatment. Ketamine ravages the body and mind, and every delay potentially costs lives. For anyone here who's in the same position I was, or is suffering, today I'm almost 7 months drug-free. My bladder pain is manageable. My liver function is improving, my stomach's healed, and I rarely need incontinence pads. I still have pain, but it's nothing compared to what it was before rehab, which quite literally saved my life and helped me to start living again. So get out there, get the help. Thank you.
Thank you, Lauren and Mikey. Back to you, John.
Thank you, and thank you, Lauren and Mikey. I won't put it anywhere near as well or articulated as good as you have. So thank you so much. And your recommendations fall into, Tier 4's recommendations as well. And I'd like to share some of those with you. And I'd also like to encourage you to consider how you can support us to improve support for people, because we're constantly looking to do that. Firstly, I'd like us to think about attitudinal change, and education is needed, and we need to challenge the stigma. Secondly, detox and residential treatment need to be considered earlier. We've heard how important that is. And when people ask for it, they need to be listened to. The funding model, we feel, needs to be flexible and dynamic to ensure people get the maximum therapeutic benefit. We need to get easier access to healthcare, such as urology and pain management nationwide. We need improved access for face-to-face and home assessments. And we need further consideration for support for those just under 18, and how we can support them to access or receive the care on par with that of residential treatment. And then we need improved support for family and loved ones to navigate the detox and residential pathway. But before I finish, I'd just like to read something from a mum whose son accessed residential treatment, because I think this says it beautifully. I cannot imagine what would have happened had the service not intervened in time and the funding for detox and rehab had not been granted. Thank you.
Thanks, John, and thanks everybody from that session on detox and rehab. I think some of those stories, particularly the lived experience angle, we'll pick up on some of the points raised in terms of urology and pain management as we come into our next session. So the next session is about urology and pain management, and then we'll finish with a section on community-based treatment. So I will hand over to Alison. I'll just start the slides and then you can take control and do your own clicking.
Thank you. I'll just get my slide up. So I hope everyone can see my slide coming up. Is that visible for everybody?
It is for me.
Yeah. Lovely. Thank you very much for involving me. So my name is Alison Downey. I'm a consultant urologist, and I work in an area that has an extremely high prevalence of patients with ketamine neuropathy, and it's only increasing. And I'm just going to share a little bit about what we've done locally that might be of use to people. I'm not going to tell you all about the urological effects of ketamine because I think we all know that they're pretty profound. But just in general, it causes fibrosis of the bladder. So you get a very small capacity bladder, pass urine up to every 10-15 minutes. Passing blood in the urine is very common. Clots can be incredibly painful. And I think the common theme throughout this is the pain is absolutely horrific. It's a combination of a neuropathic pain because you get upspreading of the neurons in the bladder, but you also get a bit of ischemic pain where you get a lack of blood supply because there's damage to the blood supply of the bladder as well, and it is absolutely horrendous. In some patients that can progress to obstruction of the kidneys, which is a real problem when we need to put nephrostomy tubes in to drain the kidneys. And also has an array of other physical problems. So I think Mikey mentioned about erectile dysfunction in about 30% of men, painful for women to have intercourse. There's a high rate of things like K cramps. You can get ketamine cholangiopathy where it damages your liver. There's certainly a risk of cognitive impairment, and I've had a few patients who presented in profound heart failure as well. And one of my main concerns is there a risk of cancer with this? Because if you've got a chronically inflamed, horrible bladder, is that a risk in the future? And that's an unknown risk. The urological management actually is quite straightforward. It sounds really complicated, but it's not. And I've worked very closely with my colleagues in the British Association of Urological Surgeons, and we've written a guideline on how to manage patients who are presenting with ketamine neuropathy that is open access for anyone that can access it. It's on the BOUS website. It's on the BJUI access. And actually, from a urological point of view, it is fairly straightforward in how you can manage these patients. A lot of the issues we have are from education. So when I became aware of this issue locally, these are the barriers that I faced, and I'm certain are fairly common across the country. We've talked about people just not being aware of this problem. So a lot of my patients will present recurrently to A&E with hematuria, sort of blood in the urine, and just be labelled as having infections, or nobody picks up that this is a ketamine problem. Nobody thinks to ask. GPs aren't aware that it's going on. They may be presented to addiction services and there's no direct pathway into urology to get that help. I think a big issue in the community in general is there's a massive social taboo about urinary problems, particularly incontinence. It's not something we talk about as a society, and it's definitely not something we talk about in the context of ketamine use. And there's a fear of coming to see. If someone mentioned a fear of having their bladder out, and that is a really big thing, that people think that they come to see us and we'll just want to take their bladder out, and the opposite is entirely true. Getting access is difficult, so trying to get into the GP, getting a local urologist who maybe isn't aware of the problems to take it seriously and to know what to do. And a massive, massive problem is pain. Getting on top of pain, getting the right pain management in place, getting in for pain team. And because it covers such a big array of services, there isn't actually anybody that's in charge. There's nobody that's liaising locally with everybody. There's not one person whose job it is to make sure that there's a urology appointment, that there's a hepatology appointment, that the heart team are involved, that the cessation services are in, and that makes it a bit difficult. and getting that communication as well between community and secondary care. We don't have the same IT systems, we don't have access to each other's systems, we don't have direct links in, so it's really difficult. And geography is a big thing. And I thought I'd just put up this slide to show you my local geography as a kind of example. Is that so I cover a population of 1 million. That's across 2 hospital trusts, both different trusts, different funding. I've got 4 hospital sites, 3 of which have an acute A&E department. There are 2 different ICBs. I've got 3 different substance addiction services. I've got Barnsley Recovery Steps, Turning Point, and CGL, all of which are fantastic. But there are 3 different people I then have to liaise with, and then 3 different councils as well. So you can sort of see from a clinician in a secondary care setting how difficult this is. So this is what I've sort of managed to put together. And just again to show the difficulties of this is that I have 2 different systems in the different trusts because I have different access to services. So in Barnsley Hospital, our referrals come in from A&E or GPs. We do a joint clinic with Recovery Steps. And depending on what is discussed during that clinic appointment or what medical needs are required, to then have follow-up in the community with Recovery Steps. We have a specific ketamine program. And if they need intervention, so if we need to do nephrostomies for their kidneys, or if they've managed to get off ketamine and actually do need some reconstructive surgery, we can sort that out. And if they stop using and their symptoms recovered to the point that they don't need us, then we can discharge them to the community. And it's really important to say that it's not all doom and gloom. I have a fair amount of people that have stopped taking ketamine and their bladders have recovered significantly. So there absolutely is a reversible part of this. We just need to catch people when they come to help. We need to get increased awareness so we can pick it up and get those systems in place. And then Mid Yorks, we have a slightly different system in that we've got an in-hospital substance care team. They come to clinic with us, and then they will then liaise with either Turning Point or CGL, and often follow them up with a telephone call. And again, we would then do whatever urology intervention is needed. And if they manage to stop and they don't need us, we'd happily discharge them. We still have barriers. Sorry, I've done some other work which I helped develop the consensus guideline. I've done a significant amount of education, which I think is what we really need for A&E, GP, social workers, safeguarding teams, probation service, basically anybody that would let me come to a meeting, I would go and tell them about ketamine, and that's part of it. We need to raise awareness. We need people to think if they've got a young person coming with blood in their urine or labeling them as recurrent infections, but actually their cultures are clear, asking the question, is this ketamine, and getting them that help really early. We're developing an information page with BOIS, raising awareness. So I know locally there's been a lot going on to raise awareness, particularly in Barnsley, where I think they were BAFTA nominated, which was just fantastic. And I'm seeing the results of that in clinic. I'm seeing people coming to me already engaged with services, which makes a huge difference. And ongoing, I'd really like a direct referral pathway, access to ultrasound from cessation services to kind of speed people in that really need to see me quickly, and kind of getting that direct access rather than going around the houses. But there are definitely barriers. I think pain is the biggest thing. I don't know what the best pain relief is. I try things like amitriptyline because it's a nerve pain. Best will in the world, urologists are not going to be able to manage this pain significantly well. So what we need is pain team. But the provision of pain team across the country is very postcode. I've got a fantastic one in Mid Yorks. I don't have access to one in Barnsley. So I've already got a bit of a tier system, and there's no pain pathway either. We don't know particularly what we should be working. So that's a major issue that really would be helpful. A very niche barrier that I've only just discovered is that some rehab settings aren't able to manage patients who have nephrostomies in, and particularly if they've got difficulty managing the bags themselves, and that's been a barrier for one of my patients to get into rehab. And we've got massive DNA rates, so people not coming to clinic. Sometimes it may be a transport issue, it might be a time of day issue, but that's a real issue. And one of the big things is that we often work in silos in the NHS because it's a urology problem or it's a cardiology problem, whereas this is an everybody problem. So the services aren't really built up with those links. Urology and drug addiction don't really have links already because we've never really had those problems before. And often the services are reliant on individuals. And if that person, for instance, goes on mat leave, that service can sometimes fall down a bit if you don't have someone to back it up. So that's just a little brief overview of sort of a urology viewpoint.
I think that's hugely helpful, Alison, and really good to hear about that idea of consensus guidelines and trying to build that knowledge base and good practice right across the country. Next, we have Mark, who I think will touch on some of the things that you've also talked about, particularly in terms of pain management, I think. Mark?
Yeah, I'm not sure where the slides have gone, but I've got them here anyway, so I'll share from here, I think.
You're happy to? Yeah, that's great, Mark. Thank you.
Has that come through now?
Yeah, not on full screen, but it's perfectly visible to me.
Okay, that's good.
Oh, perfect, done.
Yeah, so I'm Mark Poindexter. I'm a Deputy Head of Operations for Inclusion, and I'm going to talk to you about what we're doing in the South. We deliver the adult and young people services in Hampshire and Isle of Wight in Hampshire in partnership with Catch-22. We also work in Portsmouth in partnership with SSJ and PCC, and we're seeing growing numbers of ketamine users coming into treatment, which obviously is good that they're coming into treatment, but that, I think indicates a wider prevalence across society. We also deliver the Dame Carol detoxification service in Fareham in partnership with Two Saints. Our main age groups we've got coming into treatment are 18 to 25s and 25s to 35s, with roughly about a third of those being female, 2/3 male. So what we've got currently, which is great, is that people are successfully completing in the community and through residential treatment, and also a number of people successfully completing informally through NA and not using treatment services or partly using treatment services. Now, we've got a ketamine nurse, which we deliver in partnership with Catch-22 in Hampshire, and that person provides assessment, advice, healthcare advocacy and coordination for service users and people using ketamine, and either directly or through supporting the recovery workers and the local nurses to improve that. And I think that coordination is absolutely critical to try and help the person make a change in their situation. Trying to make that change without all the pieces of the jigsaw in place, is really, really difficult. It's difficult anyway, but if we can get the right piece of the jigsaw in place at the same time, people can and do well. We've got a dedicated family and carer support group run for us by Parent Support Link for parents and loved ones of people that have got ketamine issues. And we've done about 8 ketamine detoxes in Dame Carol in the last year, all of which were successful. And I think I would largely attribute that success to us having quite a dynamic, cooperative approach to symptomatic relief. So we don't have a regime. And, when I audited those cases, it showed a really high level of cooperation between the staff and the service user to get the medication, the symptomatic relief right over that time period. And what we learned from that is that most of the service users that we've worked with doing those detoxes, their pain was significantly improved within 7, 10, definitely 14 days. So that's kind of a good news story. Obviously, particularly if you're doing it outside a residential setting, it's going to be excruciating, but it's highly likely to improve. So 7 out of 8 of those people, it had really significantly improved. Obviously, everyone's different and everyone's bladder's different. So it's a good news story, but with a qualification, I guess. So the other thing we've got is really good lived experience involvement. We've got lots of very eloquent service users that get involved and kind of support and refine the work we're doing as we go along. However, what we need, I think, is more and better tailored interventions for people using ketamine. We have some, but we're working to improve that. We also need more stable and reliable pathways with urology and primary care. We find that we can get this in places, and then sometimes when the individual moves on, it all falls down and we've got to start building it all back again. The other thing is that pain relief is a massive challenge, and I think that people are experiencing being sent from service to service to service, you know, from primary care to urology to the plain clinic and then back to primary care. Sometimes we're not actually being prescribed anything at all. We are getting some results with amitriptyline, and that is sometimes being effective. And I just wanted to pick up on the point about harm reduction. I think it's important to be realistic, but I think that harm reduction message, as with all the best harm reduction work, it needs to be individually tailored to that person, to where they're at, what they're able to hear and understand in that moment, and without stigma or judgment. I completely agree about the scare tactics being, you know, not being constructive, and we're aware of people that haven't and have delayed entering into treatment for fear of bladder removal. And we all need to know that the first line treatment is oral medication. There is absolutely no rush to remove bladders. And, you know, we've got people that have needed to have surgery, but we've also got lots of people where the bladder has repaired and regenerated naturally following the cessation of ketamine use. So I also just wanted to touch on stigma. The lived experience of the people we're working with is that the healthcare system is complex. I think, you know, the majority of probably one of the main things our ketamine nurse does is to help people find the way through that pathway, to help their parents and their loved ones, and to support and guide people, and to speak to healthcare professionals and kind of unblock problems. There's quite a strong stigma of drug use in general. I think sometimes people think that drug use is a self-inflicted injury and people should just stop. And I think, wouldn't it be wonderful if they did? We'd all be out of a job. But also, obviously, there's that stigma associated with incontinence. And there's that kind of double jeopardy that the client feels unworthy of treatment. And you've also then got some staff that might be quite judgmental or derogatory, or at least as importantly, unwilling to adapt treatment to the person's needs because they're drug related. And because of that stigma and that shame, you've got people that are quite willing to bow out at that point and say, well, okay, I'll just carry on coping with it on my own. But, you know, I think the good news is that when we do coordinate those interventions together, we can make a difference. And something we've been talking about recently, which I don't know if anyone else is going to pick up on this, there's almost two different pain requirements. One is for that acute and severe pain on cessation of ketamine use, and then there's that kind of chronic long-term pain, which which may need to be managed for a good deal of a period longer. But I'm going to finish there. Thank you.
Right. Thanks, Mark. I think that's really helpful and lots of things to pick up on. I'm now going to get the slides back up and hand over to Rachel. We've had quite a few questions in the chat about under 18s, and we'll now hear from Rachel, who's working with precisely that kind of cohort, so can give us a kind of perspective on that.
Thanks, Will.
Great.
Oh, I feel like I've pressed the wrong button and it's gone into a different
I think you're
view.
in control. I think you're in
Okay.
control.
Can
So
everybody
go
still
for
see it as a normal view? It's come out on my. Oh, maybe I can now. Yeah, I've never taken control of slides on Teams before. Thank you very much. So thanks for having me. I am a paediatrician, which always feels like a confession in spaces where we're mostly talking about things that affect adults, albeit quite often young adults. And I'm just going to talk specifically about under 16s, whilst acknowledging that children are legally children till they're 18. And I think we've seen some things as we've gone along about 16 and 17-year-olds and complexity. But I work in a specialist children's hospital and we tend to see people till they're 16. So I just want to tell you about a few things that we're doing, which might answer some things that have come up. It might not answer some things that have come up. It might leave you with more questions than answers. But towards the end of last year, my colleague Harriet, who is a paediatric urologist, started getting referrals, more referrals of children under the age of 16 with bladder complications as a result of their ketamine use. And I think she received one referral in all of 2023, maybe 2 or 3 in 2024, and we're now up to 45 patients since the beginning of this year. And I think I was seeing in the chat about neurodiversity. I think a lot of our patients have got co-occurring need, and often that is neurodiversity, and it might be met need or it might be unmet need. And it is the clinic that we see, we basically gather everybody together for KET bladder so that they can all be looked after, generally speaking, by one urologist. And then I, as a paediatrician and a public health doctor, go and sit in the clinic as well and talk to them about their drug use. And that might be the first time that an adult has started a conversation with them in a child focused way about their drug use. And if they're not connected with our amazing local drug and alcohol services, I can do a referral in clinic and things like that. And we also talk about harm reduction and keeping safe when they're using KET, but also how to keep their friends safe. So anybody who's ever met a young person under the age of 16, they don't like always to be for the attention to be addressed directly at them. They might like you to talk about their friend. So when I'm giving the harm reduction advice, I'll be like, you know, if your friend is in a K-hole, do you feel comfortable that you know what you would do to support them? Or, you know, if your friend is doing this, and actually they take that on quite nicely, actually, on board, and they're pretty savvy. They know quite a lot about quite a lot, so it's useful to meet them where they're at with that. So that's one thing that we do at Alder Hey, and as far as we know, we've probably got 95% of the under 16s with KET bladder in England at the moment. Oh, there are a few cases that have made it to children's hospitals in other bits of England. But I also wanted to talk about, we just found out last week that we've got funding to make a children's version of that guideline that Alison shared. So Alison and I never met each other until about a month ago, and now we're best friends. But we're making a kids version basically of that. So working with Change, Grow, Live in Liverpool to do that, because there are some under 16 specific things we would need to take into consideration. So they're things that might affect older young people, but are particularly pertinent to under 16. So things around safeguarding, you know, if people are being groomed or at threat of exploitation, mental health issues, you know, are managed in a different way. And I think as paediatricians, we're quite good at managing complexity in children, whilst acknowledging that you know, services should be the service that we offer should be available on lots of other locations, not just where we are. If anybody is particularly interested in that, please get in touch. There's only one Rachel Isbar in the country, so get away with nothing. So I'm quite easy to track down on the Google. And then something else I'm just at the very beginning of journey about is that some of our bladder clinic patients need extra support, but they're under the age of 16. And you'll have seen in the presentations that we've just seen that it's tricky if you're 16 or 17 and need detox. If you're under the age of 16, and please correct me if there is a service I don't know about, if you're under the age of 16, there isn't anything for you if you need inpatient detox. So I've just got some funding from our charity to start co-designing an outpatient based approach, and again in partnership with our local community drug and alcohol providers. Alder Hey covers all of Cheshire and Merseyside, which is 9 local authorities, and So I'm working with Change, Grow, Live, and then some of the other local providers as well. And the way that I'm thinking about it is sort of two wedges. So it's going to be bio for the medical bit, including getting on top of the pain, getting on top of the having to go to the loo every 20 minutes, but also the psychosocial bits of that you might see more in rehab and recovery phases from the beginning, and a sort of wedge of medical that decreases and a wedge of psychosocial that increases. And that's where it's vital that we work with our community partners from the very beginning. And I think that's quite an unusual approach for a specialist hospital like mine to take. So I'm quite excited about that. Again, if that's something you're interested in, please do get in touch. And then this is like hot off the press. So I'm trying to fill in all of the paperwork at the hospital at the minute to be able to routinely offer in a sort of very normalized way naloxone to children and young people and their parents and carers in our CET clinic, because we also have the nitazines issue in Cheshire, Merseyside, and fentanyl as well. And if anybody is aware of any, in fact, Al, I'm going to come to you if that's all right, because I would like to make a TikTok about how to give naloxone in the community, because I think that's probably the best way to train the young people. There's training available for parents and carers. I don't know, maybe they want a TikTok too, but I would really love to do something that's age appropriate. And Al, you seem far cooler than I am, so I'm going to come to you in the first instance.
Some may say,
okay.
some may not.
Well, and yes, so so I just want to normalize this, and I think also that might help with stigma around generally calling for help if you've had a negative effect acutely of taking drugs in the community. So for me, that's quite exciting, and that came from something that a young person said in clinic. So I think that's me. Yeah, Brill. Thank you. Will, I think you're on mute. Yeah.
Still on mute, Will.
You're still on mute.
You unmuted
Okay,
yourself
too
for
many-
like a beat and then unmuted
There's
again.
too many things flashing up to try and take control of. But yeah, brilliant. Thank you, Rachel. That'll fill gaps for people. And I will hand over to Ginny. I think you've taken over the slides already, Ginny. Yeah?
Yes, I have. Thanks,
Magic.
everyone, and thanks for inviting me here today. So I'm here from Early Break, which is a young people's service in Greater Manchester and Blackburn with Darwen. But I'm also here representing the North West Young People and Families Substance Use Partnership. So I'm just going to give you a quick overview of that and kind of update people on where we're up to, voices of young people, but also services, academics, and the work so far. Okay, so who's the partnership made up of? There's the great and the good, and anyone that's interested is more than welcome. It's basically a group was set up around horizon scanning, around new and emerging substances, around and risk-taking behaviours for children and young people. We've probably been established quite a number of years now, pre-COVID, but ketamine has been one of our journeys. So moving on. So the work that we actually have been undertaking is the way that we work is we come together. First of all, it was Greater Manchester, and then as the interest has grown, it's expanded to a Northwest group. So basically, we come share our concerns or anything new and emerging, then we bring our data together. Based on the data, we have MMU, Professor Rob Ralph attends that, and various other academics have an interest in specific themes. So we look at young people's drug trends. A lot of our research is based on the drug trends information, and then further specific research has been undertaken over the years. Last year, we was invited to deliver, I think, ketamine event in Manchester, which taken place, and that was to bring together both young people's drug treatment services, adult drug treatment, primary healthcare, mental health care, and neurology. And we all came together to kind of look at, no surprises, we all had the same concerns, but recognise the value of developing a multidisciplinary team response. So there was our recommendations. So just moving on to the next slide. So some of the Yeah. So some of the emerging themes that we have learned from the recommendations is we knew that young people had fell through the net. I think over the last, oh, actually I've jumped a slide too much. Sorry about that. So I think where we're up to now is I think over the last 18 months, we've worked really hard in terms of looking at the British Association of Urology research, and we've really focused on those stage 1 and stage 2, bringing treatment together and bringing systems together. What we realise is one of the things that we have missed is as part of the group, we've realised that we're getting children still presenting to us at an earlier age. And one of the things we really need to do is shift our prevention work downstream so that we're really targeting those young people at the ages of from 12 up to under 16. We call these the untouchables because if you can remember being that age, nothing had ever happened to you because you was far too young. So it's thinking about those pre-stages. What is the sensible education and harm reduction information that we need to give them? Because at the minute, all the information out there tends to be around stage 2 and stage 3. So it's about looking at that age group. What is it that they need to know based on health harms, based on, sensible harm reduction, really. Considering, if we tell them to stop using, taking breaks, etc. And much of the young people that we've involved in some of this work have said as well, we're not going to listen to the information that we've given. We know it causes damage and we know it causes harms. But, a lot of our young people and our mates don't have that problem. So it's just picking up on Rachel's comments around, what does harm reduction look like for those age groups, really. So moving on then, some of the themes that we looked at is breaking it down to looking at ages and stages. So looking at the ages 12 to 14, looking at what does harm reduction look like. Young people suggest around, looking at what health information do they need to have, what harm reduction is appropriate to them. We know that as drug services, we all feel from the group that actually very few, and I know there is very few young people that in our cohorts that have the ketamine neuropathy under the age of 16, where they do have them, they're few and far between. And we do know that community-based services have quite a good success rate if they get in there early enough to those young people. So if we can get into those schools and those education services, or working with our colleagues in education or healthcare and get those referrals through, we know that our outcomes are quite successful. So again, it's about undertaking some research to say, what is it then with that cohort that makes it work? And does that cohort then go to represent or go on to relapse? Because what we know with ketamine is that we know that it is a relapsing condition. So more research to be done, and this is some of the work that's taking place currently and will be taking place over the winter. We felt that, and information and services have felt that we need to be more responsive than reactive. So when we spoke to young people about, what was helpful to you, there was some instances where we have accessed, young people have wanted to go into drug treatment and then wanted to go on to detox, but actually when they realised it was a little bit too quick too soon and they wasn't yet ready. So it's about getting that balance, particularly where we've got neurodivergent young people as well. I think some of our pathways has been completely around a lot of young people increase their ketamine use around loneliness, around mental health. And then when they've been going into detox and they're saying they're taking the phone off them, then actually it's increasing that isolation for them. So just kind of trying to really unpick what does this mean for young people. And then again, young people, we talked a lot about stigmatization. So, and young people and the word and the language we use in terms of recovery, that young people don't see themselves, as a 15-year-old. If you're talking about a 25-year-old, that's like talking about an OAP, really. So just really getting those messages. So my final slide is to bring it all back together, is what does good old-fashioned drugs work look like? Let's keep it simple. Let's understand what works, and really looking at those ages and stages, because we want to prevent them young people accessing being, the ketamine use escalating into treatment and detox where possible. Ensure that where we've got detox, having a look at what's worked, and certainly there's work around parents here. We know that, there's no quick fixes when we're talking about young people and ketamine use, particularly those where there's co-occurring conditions. So how do we support parents in this? We know that quite often there's a reactive thing as well, and we've got experience of some parents paying privately to have their children detoxed, and that's like tapping into pensions and life savings. So again, how can we get this system right? I've spoke about we've all spoke about pain management again, but just thinking about with that younger cohort, how do we speak differently to them? Absolutely spot on, Rachel. Let's talk about the friends and the mates. Let's not talk about them directly. And then again, let's, as professionals, consider how we talk about ketamine to each other and about young people. Thank you.
Thanks, Janine. That's really helpful. Donna, would you like to take control of the slides?
I've only got that one.
Yeah, well,
Yeah,
I'll click then. That's no problem.
I've clicked.
Okay, great.
Thank you. Hello, everyone, and thank you for having us today from Barnsley Recovery Steps. So we are seeing a year-on-year growth in people who use ketamine in our community. We're seeing a younger cohort of people accessing the service or with significant chronic physical health issues, along with mental health issues as well. We are using inpatient detox and residential rehab, which seem to be effective, but options around that are limited, but we can't offer that to everybody due to funding restrictions. And for some people, it may be too early on in the recovery. We're finding that people who are not yet affected physically by ketamine or our younger cohort are not wanting to commit to that as an option. We launched a ketamine campaign earlier this year and spoke to people within the ketamine community about what they felt they needed. And a lot of that their feedback were around peer support, mutual aid provision that was specific to their needs. They were talking about attending CA and NA and feeling quite ostracised due to needing to go to the toilet every 2 minutes, experiencing different kind of reactions to the drug use when they were talking about it within the group, people not understanding what it were. So we've looked at our community pathway, looked at provision, looked at issues preventing people from recovering, and we've sort of started working on a community detox option, so that's more widely available to everybody and not as costly on service provision. So we're looking at forming an MDT approach. We've got a really good relationship with Alison from urology at Barnsley Hospital, and we're starting to look at an MDT approach where we've got someone from urology. We're hoping to get GPs on board, mental health teams, our service, and discussing each client that would require all of them different interventions at that MDT and forming a pathway for them, so that we can look at community detox, relapse prevention prescribing. We're looking at piloting naltrexone and looking at effectiveness of that as a relapse prevention medication, and then linking into community options such as mutual aid or recovery hub provision. All of that underpinned by harm reduction interventions, advice, guidance, naloxone, nitazene testing strips, all that sort of thing to sort of carry that person through treatment. It's really early on in its stages, but we do know that we need to tailor our approach to meet these needs, because as it stands, we're all kind of
leaving these people in pain is what their feedback were. They were stopping the drug use, they were attending recovery groups, but finding it really difficult to access pain relief from the GP surgery due to stigma of being a drug user. They've got that kind of view of people, it's drug seeking behaviour, seeking pain medications, benzodiazepines, that sort of thing. So we're looking at incorporating that into our pathway and finding different ways to engage these people into treatment that they need, really. So next step for us is to continue working on that. And that's all from me.
Magic. Thank you, Donna. I think that's a really clear outline of how community services are working to try and make services accessible, but also coming back to that point, I'll pick up on it from Mark's presentation earlier about making sure that the support is dynamic and tailored to that individual. So Mark was talking about it in the context of detox, but the same would apply to that community option as well. I'm going to hand over now to our final presenter, James, who is, I think, going to reflect a little bit on that wider sense of how we can build services that are accessible. So that broader point of this isn't necessarily, there's stuff we can learn from these discussions around ketamine specifically. So yeah, James, go for it.
Thanks very much. So just to finish off, my name's James and I am the Senior Social Worker from Liverpool CGL. But I oversee the ketamine pathway in both Liverpool and St Helens, and this is just some learnings essentially that and just some thoughts to provoke some further conversation. So essentially, in terms of accessibility and early intervention, it's about how we reframe our services essentially as moving away from the stigma that's attached to drug and alcohol services and looking at the health and well-being side of things of what we actually offer. And the aim of that is to promote early intervention from the perspective of, somebody who is using ketamine less frequently and starts to develop some of the side effects or symptoms that you might later on experience, and then thinking in their first thought, I need to go and access that service that I know does that work around that. So it's about how we reframe our services to meet that need. The other thing is about how we can educate not just the person who's in substance use, but also those around them as well. So we've talked a lot about family support, but what we're talking about there is later on down the line when people are already in difficult positions, it's how we get that education and knowledge to them much earlier on in the process. And so some of the things we've done is developing guides around for parents in terms of educating them around ketamine use, but bigger than that as well, in terms of people that may come into contact with things. So thinking about that nighttime economy, developed leaflets and guides for club owners, festival organisers and taxi drivers. So again, that they're able to develop their own knowledge around how to spot the signs and what to do when they come into contact with somebody who potentially is under the influence of ketamine. A focus on removing red tape and long-winded assessment processes that sometimes people have to often go through, and how we can do that in a more relationship-based way. So one of the things I'm really keen on is that we're meeting people where they're at. That means that as a sort of recovery coordinator, I'm coming out into the community, meeting the person where they're comfortable, whether that be an Aldi car park or whether that be their home environment, whatever it is, wherever they feel more comfortable, learning about them as a person from the minute we actually speak to them. So we're able to adapt the service around them, understand what needs they've got, and adapt our service to meet their needs. So again, sometimes that means we need to go out, sometimes that means we need to do sessions and our one-to-one support in a completely different way, adapting it to things like people who've experienced trauma and who've got neurodivergency, making our sessions shorter, more straight to the point. So I've developed a range of 15-minute off-the-shelf one-to-one sessions that we can use, that we can just pull out when needed, and that extends to things like harm reduction, but also recovery as well. There's something about how we create an entry into treatment system that's holistic and looks at the whole person. So we've got early screening mechanisms for not only the recovery, the substance use side of things and someone's health, but also things like trauma and mental health support, looking at how, as community services, we can do additional screening mechanisms like screening for kidney damage and screening for more in-depth assessment of urine samples, etc., which works towards preventing the need for people to have to go to hospital services, but also enables us to give our service users who we know have difficulty accessing hospitals. We know that sometimes it's a battle to get service users to go to hospitals because of the experiences that they've had previously. A way for us as community services to be able to provide them with more education around what's currently going on for them, and potentially, you know, stop the need for them to go to hospitals in the first place. Something about how we handhold people through this process as well. So as a recovery coordinator, I go to hospital appointments with them, I go to GP appointments with them. That means that I can link in directly with the GP there and then, and we've already got an MDT approach to their treatment and their support. I can help educate and raise awareness around ketamine on the ground, and so can a GP in terms of health impact to myself. Then there's something about how we rethink our service design, like thinking about how our younger people and the clients of the future essentially consume information. We've already, I know Finley's already left, but we've got a range of online ketamine groups and we need to use them to our advantage. So one of the things I've done in terms of our pathway is completely eliminated face-to-face groups as a primary option, so that people aren't put through long-winded processes to access detoxes in terms of you've got to attend 4 sessions or 4 groups, etc. But we use the online groups at our disposal that have less limited barriers to them, and are more accessible and are more in line with the younger population and the way they consume and access information. But also looking at, as I said, making the session shorter, and really leaning into that peer visibility, getting other young people to educate. One of the biggest ways that I've engaged young people into service is through other young people. That's been my biggest mechanism of engaging, through word of mouth, through relationship-based practice, and getting them to go to their friendship groups, talk about the service, talk about the support offer, and that will encourage people because we've already developed trust because they trust the friend. So that's one of the biggest ways we've engaged people into service. But using that peer model of support and that peer recovery support. And just one last final point to leave everybody with. This shouldn't just be about ketamine as well. This should be about how we respond to all substances and how we reshape and redesign our services for the future generation, essentially, because, you know, what we're seeing now is going to be how we need to change our work for the future. And that's it from me.
Great. Thank you, James. That's really clear. And I think the perfect kind of call to action at the end to say that, yeah, this can be and should be about more than just ketamine. There's things that we can learn from the approaches that we're having to take. We can improve our horizon scanning. We can improve how we work in partnership with different bits of health and social care and the wider education system and so on. We need to make sure our services are flexible and dynamic and responding to what's actually happening and how people are behaving and how they understand what they're doing as well. All those points are really important. We are well behind time, so I'm hugely grateful for those who've stayed. It's quite amazing to me that even though we've run over, we've still got well over 200 people on the call. So it shows that there's a real interest across the field in getting this stuff right and improving what we're doing and working together. So I'm hugely grateful to those of you who've stayed through to this point. I want to say a massive thank you to all the presenters, because the amount of effort that's been put in and the different perspectives that we've been able to bring together today has been hugely positive for me, and I have been quite demanding in terms of trying to make everybody squeeze what they want to say into a much smaller amount of time. I've followed the Q&A quite closely, as has Maisie. I think lots of the questions actually in a way have been answered as we've gone through. So people were asking about under 18s or they were asking about detox. I think there's a few things we'd like to follow up specifically afterwards. So we'll share the slides, we'll share some bits of guidance. We'll also share some specific responses. So there was a question about support for families and parents. There was also a question about what does detox really involve. I think those are best answered by going back and making sure we've got a kind of consensus and pulling together different bits of information from the presenters and our wider network. So we'll come back on those specific questions. I'm really interested in what we do next, which is build a network and make sure that we're actually sharing resources. Al talked about that in terms of harm reduction. Can we share messaging? Can we share resources? There's definitely opportunities, and I can see people have been connecting through the chat. But if there's anything people would specifically like to put me or others on the spot about now, then please raise your hand, and we can pick that up now. But I think I'd just like to say again, huge thank you to everyone who's presented and everyone who's attended. This is genuinely just the kind of beginning of a conversation that we want to be part of as Collective Voice across the network, across the field. So please don't see this as the only opportunity to talk about these issues. If anyone puts up a yellow hand, we'll unmute you and allow you to put a panelist on the spot. But I think everyone has many places to be and things to do. Great. Well, I would just say one more thank you to all the presenters and everyone for attending. And yeah, just get in touch with us through our email or other social media routes. And to flag, we are running another webinar on the 25th of November, marking UN International Day for the Elimination of Violence Against Women and the launch of 16 Days of Activism. It's been coordinated by our Women's Treatment Working Group, which is one of many forums we run that bring together practitioners and other wider people across the sector. So please look out for details of that. We'll be publishing it in due course, and we'll pop it in the chat if it's not there already. So thank you again, everybody. Appreciate you taking the time. I'm going to stop recording.